This conference will now be recorded.
Good morning, everyone. Today, my topic of presentation is deep vein thrombosis. I am Dr. Avinash, second year radiology PG. The indications for venous ultrasound is mainly for diagnosis or exclusion of deep vein thrombosis in the upper or lower limb, spontaneous or related to indwelling catheters, assessment of secondary or recurrent varicose veins, investigation of chronic venous insufficiency and post phlebitis syndrome. Phlebitis is inflammation to veins either by several causes, and vein mapping prior to bypass grafts, assessment of primary varicose veins if there is uncertainty following clinical examination, and localization of veins for cannulation. And to do the venous ultrasound, one should know the anatomy, and the anatomy of lower limb veins are divided into deep and superficial systems. These are linked by various number of perforator veins which carry blood from superficial to deep systems. The veins of lower limb are superficial veins, GSV and SSV, great stiffness vein and short stiffness vein, and deep veins are deep veins in calf are anterior tibial, posterior tibial, and peroneal veins, and in thigh we can see superficial femoral, deep femoral, and common femoral veins, and in pelvis external and common iliac veins. This is a picture representing the course of veins in lower limb, and one should know the anatomy of the veins to know where the thrombus is, from in which vein the thrombus is present or the varicose veins are present. Out of the veins, the GSV and SSV are important, and they are GSV begins in the foot and passes anteriorly to the medial malleus and extends from the ankle to groin along the medial aspect of leg and thigh. About 4 centimeters below the inguinal ligament, it dives through the muscular fascia and joins the common femoral vein. Most commonly used as conduit or graft for coronary and peripheral arterial reconstruction. Isolated thrombus of GSV is relatively common. And SSV, it lies between two heads of gastric nervous muscle along the posterior aspect of calf. It extends from just above the ankle to the popliteal fossa, empties into the popliteal vein. Like SSV, like GSV, short stiffness vein, may also be used as a conduit for bypass surgery. It also may be a site for thrombus formation, with the possible extension of thrombus into popliteal vein. And the course of the pictorial representation of course of long stiffness vein along the medial aspect of leg, and in the posterior aspect we can see the lesser stiffness vein, which is soft stiffness. And the technique for extremity, technique for venous examination through ultrasound requires the instrumentation like ultrasound frequencies between 5 to 15 megahertz range are used, and excellent grayscale resolution is required for imaging, and a Doppler device that is sensitive enough to detect low velocity and venous flows. Due to thrombus, we can get decreased blood flow, and which should be detected by the Doppler device. And the power flow or power Doppler should be present, and the color flow should be present to see whether the vein is filled or not. The image orientation is seen in long axis or short axis of the vein, and the short axis is known as transverse axis, and long axis is known as longitudinal axis. And the intermittent compression is used in short axis, that is in transverse axis. Pressure is applied with the transducer and causing the vein to collapse. Pressure is then released. The transducer is moved 2 to 3 centimeters along the course of vein, and the compression is applied. This process is repeated along the course of vein. This is present. Generally, veins are um, uh, veins will collapse when we apply pressure. So, if any thrombus is present, the veins won't collapse. And this should we have to move the transducer we have to apply pressure for every 2 to 3 centimeters to know where the exact location of thrombus is present. And this is an example of popliteal segment where uh, we have to this is ultrasound transducer, and we have to see the popliteal vein along its course at popliteal fossa, which is present posteriorly in leg. And we can see popliteal vein and popliteal artery. When we compress, the entire artery will be compressed, and the entire vein will be compressed, and the artery won't compress. And coming to DVT, DVT is deep vein thrombosis is major cause of morbidity and mortality all over the world. The main cause of mortality is due to the pulmonary embolism, which is a complication of DVT in the lower extremities. Ultrasound remains the workhorse of detection of the extremity venous thrombosis. CT and MRI are commonly used to either visualize thrombosis in central veins or test the presence of the complications which are present due to DVT. And the risk factors for deep vein thrombosis are prolonged immobilization causes uh, thrombosis, and the OC pills or estrogen replacement may increase the thrombosis formation, and the surgery or postpartum period is increased risk for DVT. Trauma and severe burns, varicosities of lower extremities can also cause DVT. Indwelling vascular device also external agents also cause deep vein thrombosis. Widespread malignancy from surrounding structures, and primary hypercoagulable states like protein A, C, and S deficiency may also result in formation of thrombus in the deep veins. And the Virchow triad in DVT represents the triad which contains endothelial damage and flow stasis and hypercoagulable states, which results in the formation of thrombus in the deep veins. And one should know the difference between the acute and chronic thrombus. The acute thrombus will be seen as anechoic or hypoechoic, and in chronic, as the stage progresses, the hypoechoic nature of the thrombus in vessel changes to echogenic stage, means which appears bright on ultrasound image, and anechoic means which it will appear dark on ultrasound image. The expansion of the, we can see in acute stages expansion of the vein is seen, and in chronic stages the contraction of the vein is seen, and in acute states some compression is possible. When we apply pressure with the transducer, the vein can be compressed a little bit in acute stages, whereas in chronic stages the vein becomes incomplete due to complete filling of the thrombus in the vessel. And the thrombus contains tail in the lumen, as the growth of thrombus is very little in acute stages. We can see a tail in the lumen, and in chronic stages clot adherent around the wall, which means it is entirely filling the vessel lumen. So the in acute stages very little collaterals are formed, or we may not appreciate the collateral formation in acute stages. In chronic stages we may see collateral formation. So in chronic stages we can see increasing echogenicity, contraction of the vein, and incompressibility is seen, and the clot adherent all over the vein, and collaterals are seen in the tissue. The types of DVT are unilateral DVT. DVT usually develops in one leg, and in certain conditions we can see DVT in bilateral conditions like metastatic adenocarcinoma and thrombus extending proximally into the IVC. Diagnosis of DVT includes clinical evaluation by the clinician, and D-dimers test, MRA, contrast venogram, and color Doppler are seen. But out of all this, generally clinician prefers for D-dimer and color Doppler. And clinical presentation includes leg pain, pain in the leg, swelling, erythema, and examination gives information like tenderness and warm limb, dilatation of superficial veins, positive hormone sign is seen. And the well score is very important in diagnosis. The well score includes scoring to each condition, and in which the well score, if more than 2 in the total of these conditions, it is more the probability is likely to be deep vein thrombosis. And so the conditions are: in active conditions, the score is +1. In paralysis, paresis, and recent immobilization of lower limbs, by paralysis or paresis, it is the score is +1. And recently bedridden for 3 days or more, or surgery within past 12 weeks in general or regional anesthesia, the score is +1. Localized tenderness along the distribution of deep venous system is +1. And the entire leg swollen with the well score is +1. The calf swelling at least 3 centimeters larger than the asymptomatic side, the score is given as +1. Pitting edema confined to the symptomatic leg is +1. And collateral superficial veins, which are not associated with varicose, are +1. Previously documented a deep vein thrombosis is +1. Alternative diagnosis at least as likely as greater than the DVT is +2. It's -2. And the score of 2 or higher indicates the probability of the deep vein thrombosis. The score is less than 2. It indicates that deep vein thrombosis is unlikely. So, which may not be present as deep vein thrombosis in the diagnosis. In patients with the symptoms in both legs, the more symptomatic leg is used for ultrasound examination. Causes of D-dimer elevation along with deep vein thrombosis are malignancy, liver disease, trauma, high rheumatoid factor, and pregnancy. In inflammation and recent surgery, we can see recent D-dimer. So coming to sonographic features of normal veins, the normal veins are having thin wall, which is smooth, and anechoic lumen and compressible, and which means that the vessel appears generally dark in ultrasound examination. On normal beam mode ultrasound, the vessel wall is thin and smooth. The vessel wall appears dark, which is anechoic, and which is compressible when pressure is applied with transducer. And the spectral or color Doppler, spectral means which shows the velocity in the vessels, and color Doppler means it shows the color filling in the vessel, which represents the which represents there is a flow in the blood vessel, and the direction of flow can be assessed by color Doppler. And the spectral and color Doppler features shows spontaneous flow, phasic flow, and phasic flow means which decreases with Valsalva maneuver, and which means the phasic flow mean it varies with respiration. So we will assess that phasic flow with Valsalva maneuver, and we can see flow augmentation, which means increase in the flow after in the distal region of the spectrum when compressed with ultrasound. It is unidirectional flow. Unidirectional flow is seen in vessels. And the ultrasound diagnostic categories criteria for DVT are there are direct signs and indirect signs. Direct signs include intramural thrombosis, where thrombosis can be seen inside the deep vein thrombosis, and incompressibility, increase in venous diameter, and no flow is seen in pulse Doppler, and no flow is seen in color Doppler. And indirect signs includes loss of HCT, which means by Valsalva maneuver, the proximal thrombus is seen in proximal to the spectrum, and the loss of augmentation is seen in distal to spectrum in thrombosis. And the intramural thrombosis where we can see hyperechoic nature in the vessel. Normal vessel shows normal vessel is hypoechoic, in which entire vessel is seen as dark, and in deep vein thrombosis, where thrombus is present, we can see hyperechoic nature, and here also we can see hypoechoic nature, and the color filling is not seen in color Doppler, where the lumen is filled with thrombus, where the flow is not present. The color picking is not seen by color Doppler. And we can see the collateral formation in chronic DVT, in which in surrounding tissue we can see the flow of blood, which represents the growth of collaterals in the region of in the region of vein, where we can see the thrombosis. These are collaterals present near the deep veins, where thrombus is seen. And the compressibility means in normal ultrasound we can see artery and vein. As veins are compressible than arteries. So when we compress, when we apply force with a transducer over the skin, we can see the compression of vein, and the arteries are not generally compressed, where we can see only artery, and the vein is not seen when compressed. And augmentation means when we apply pressure and see in spectral Doppler, we can see the velocities with the spectral Doppler, and with the application of pressure and sudden release, we can see peak in the velocities. This is known as augmentation. And when thrombus is present, as the flow is slow, sometimes we may see sluggish increase in peak, or absent in the peak. Problems and pitfalls in diagnosis of deep vein thrombosis are swollen edematous fat legs, where the assessment is difficult through ultrasound, and the dual thigh and popliteal veins, non-occlusive thrombus, where the thrombus is very small. We can see compressibility and we can see compressibility, augmentation, and everything as normal vein, and a segmental calf vein thrombus and segmental iliac vein thrombus, which are difficult to assess, and pregnant patients. Other causes of leg swelling and pain or tenderness includes popliteal cyst, hematoma or muscle injury, superficial thrombophlebitis, iliac nodes, and pelvic masses, AV fistulas, and lymphedema. And my references are Jubel and color Doppler ultrasound in Allens. Thank you.